I see this online all the time of strengthen your pelvic floor, strengthen your pelvic floor. You need to strengthen so that you're not leaking. Your pelvic floor muscles, you can consciously control. You can squeeze them, you can release them, which is great. That prevents you from going to the bathroom when you don't want to go to the bathroom. But your pelvic floor muscles are also innervated by your autonomic nervous system. So there's a part of these muscles that you don't have full control over, like conscious control, thinking control. And because of that, sometimes you'll get a muscle guarding response, a contracting in these muscles. You're not consciously contracting them, but it's happening. It's almost like a protective mechanism, and it's just your body trying to protect you. So those muscles can get really stiff and tight, which can sometimes lead to pain or dysfunction, and that could show up as incontinence or other issues. The root cause is actually a tightness, a gripping in your pelvic floor, and you have to address that before you get into the power of the muscle, the actual strength component of the muscle.
Welcome back to the Yoga Posers. Today's conversation with pelvic health physical therapist and yoga therapist Dana Podell begins with a deceptively simple question. Is the pelvic floor really a floor? We explore the anatomy of the pelvic floor, why many symptoms are caused by tension rather than weakness, how surgery and life transitions affect pelvic health, and why breathing may be one of the most important tools for restoring healthy pelvic floor function. If you've ever been told to just do your Kegels, this episode may change the way you think about your pelvic floor entirely. Hi, I'm Sarah Westbrook. Welcome to the Yoga Posers. And with me today is Dana Podell. I said your name right.
You did.
And with me today is Dana Podell, a physical therapist and a yoga therapist. A magical combination. And you even said to me, when I was asking you about the pelvic floor, you were like, yeah, I think the yoga therapy part is the missing piece, which is what we're going to get into today. We're going to talk about the pelvic floor. We're going to talk about pelvic floor therapy. We're going to talk about the intersection of yoga therapy and pelvic floor therapy. So you can hop onto YouTube and then we'll show you the anatomy of what we're talking about. There'll be some visuals that will really help you make sense of what we're saying. And you can subscribe, like, share that channel. We really appreciate it. Please like, rate, review the podcast so other people can find it. That's how things work nowadays. So how long have you been a physical therapist?
I've been a PT now. I'm coming up on 5 years. So I feel like that's a big milestone, reaching that 5-year mark. And I was really lucky because I got to learn about pelvic health in my last clinical internship as a grad student. And a lot of PTs actually get into pelvic health later in their careers. It's a little bit more common. So I love talking about the pelvic floor, and I'm just so grateful that I get to do that today with you. I think this is what I live and breathe. I talk about this all day, every day, and I think there's a lot we can talk about.
Right. And let's get right into it, starting with the word floor. Are you a fan, not a fan, necessary evil?
I'm not a fan of the word floor because floor to me sounds hard, rigid. It makes sense. Your pelvic floor is the floor of your pelvis. It's the bottom of your pelvis, but it's really a diaphragm. Your pelvic floor muscles act as a diaphragm because they're involved in breathing. And that is one of the best ways, I think, to work out your pelvic floor muscles is through breathing and also through different positions with your breathing. But when you're breathing, your pelvic floor muscles are moving all the time. Even as we're sitting here right now, there's a little bit of movement in those muscles. So it's more of a diaphragm than a hard floor. So I prefer the word diaphragm.
Yeah, it's such like an anatomical word that, you and I know and relate to, and it relates to the respiratory diaphragm. So any sort of horizontal structure in the body that moves up and down, it's muscle, it's connective tissue, it's moving, it's dynamic. Do you actually use that word with clients or patients?
I do. I use the word pelvic floor a lot. I sometimes even call myself a pelvic floor therapist, even though really it's pelvic health. The health of your whole pelvis is the specialty, because you look at bladder health, bowel health, sexual health, vaginal health, your whole pelvic structure, the muscles, the bones, the joints.
Yeah.
Pelvic floor is quite a buzz term, I think, in the past 5 to 10 years. So it's just the word pelvic floor people are more familiar with. I do use it with clients, but then I try to really describe exactly what these muscles are and how they function and what they actually do.
Yeah, because that pelvic floor, with my understanding of the pelvic diaphragm, it's not just what's at the bottom, but it continues up
Right.
along the walls of the pelvis. And we have our little pelvic model here. Do you want to orient us?
Yeah. So this is the female pelvis. I love this model because it's more to scale. This feels actually like a woman's pelvis. I have another model in my office that is much smaller, and it's not to scale. So this is a really good
Barbie
one.
pelvis.
The Barbie pelvis, really. Or it's almost like a child's pelvis. I'm like,
Yeah.
this isn't a grown woman's pelvis.
Right.
But when you're looking at this, right here is the front. This is the pubic bone in the front. These are the two bones on the sides, right? The bottom is the floor, but it's the muscles, the pelvic floor muscles are on the bottom. And just like you were saying, it's a bowl. So there's a backside and inside.
Let's bring it right up close to the
right
camera so we can see. So all of that red is muscle.
Yep.
Yeah. And then to see it from the bottom view, to get that span from the pubic bone, pubic symphysis, all the way to the tailbone, and then, across to the two sit bones, you really start to see like, wow, this has a bowl-like shape.
Right.
And so sometimes people call it a hammock. I don't know how you feel about that term.
Yeah, I like a hammock because that's what it looks like. It attaches from the front and the back. It's a hammock, though, that would attach to 4 trees rather than 2 trees. If you had a hammock that's hung up in a park, right? You can imagine it actually attached to 4 stable structures. The 4 stable structures are the bones. You have your pubic bone in the front, your tailbone in the back, and your 2 sitting bones on the sides, and it creates a diamond shape.
Yeah.
Yeah.
Ooh, I love getting into this with you because there's just so much to explore. So it's not just one thing.
Right.
It's this dynamic thing that has sections, and different sections can be too tight and different sections can be too loose, short or long.
Right.
So how do you want to approach that, just to introduce our audience to those sections? Is that relevant to how you do your work?
It is diagnostic and clinically in terms of pain. If you want to figure out where you're having pain and why you're having pain, I'll come back to the model because you have to see this in the model. There's technically, anatomically, 3 layers to the pelvic floor. These models typically show 2 because one of those layers is just fascia. Not just fascia. Fascia is very important. But it's fascia, so it's harder to see. So the models will usually show 2. But there's this outer layer that makes more of a triangle that you can see here. It's called your urogenital triangle.
Bring it up really close.
Yeah.
Yeah, there we go.
And it's this outer one that is typically, you'll have pain here if you have pain with any sort of penetration, pain with sex, pain putting in a tampon, pain at a gynecological exam. Typically, it's these outer ones. Sometimes even these guys up here will become painful, but it's more superficial and it's more on the outside.
She was showing the half of the diamond that's towards the front of the pelvis.
Right, this triangle here. And then in the back is around your anus and your rectum in the back there. That can also become painful. Do you know if this comes off, this top layer?
You can try.
Well, let's see. My model, it comes off. I'm not sure.
You can separate the whole pelvis if you want.
Okay. Oh, yeah, it does here. Okay, I'm going to do this. All right. Oh, actually, this is kind of a cool way to see it. All right, so here, this is that first outer layer. Then there's this deeper layer inside your levator ani muscles. It's the name of the group of the muscles. That would be involved typically with more persistent chronic pelvic pain. Can also be pain with penetration. This muscle can get injured during birth, during a vaginal birth. Same with the outer layer as well.
Does this continue up through the inner face of the sacrum as well, or not?
No, it attaches right at the tailbone and a little bit at the bottom of the sacrum here.
Okay.
Yeah. You do have ligaments, though, that support your organs. So this is the other part of your pelvis.
She's holding up the uterus and the
Yeah.
bladder.
Do you want to hold this?
Yeah.
And then I can show this part. Bladder in the front, uterus in the middle, rectum in the back. And these are not just floating in your pelvis, right? If they were floating, they would get all mixed up and around and tangled. They are anchored in place by ligaments, and there's a lot of ligaments that are holding them up. And you actually have a ligament that attaches from your uterus to your sacrum. And oftentimes you can have sacral pain on your period or during pregnancy if your uterus is changing, right? If it's getting more full right before menstruation or during menstruation, or if you're pregnant, and it can kind of tug on that ligament and then actually affect your sacrum and move it a little bit. Sometimes those ligaments can get a little bit lax and have less integrity to them, and things like prolapse can start to show up. Prolapse is when the position of these organs begins to change. Either the bladder, the uterus, or the rectum will start to drop either forward or back or down into the vaginal canal. And usually the primary reason is because the ligaments that are suspending them in place become really loose and they start to sink with gravity. But then you have your pelvic floor on the bottom that acts as this wonderful support system.
And would someone who's experiencing that sense that as bulging pressure, how they would feel that change where the organs or the internal structures are starting to descend or shift?
I'm going back to the model. This is great. So this is the inside of bladder, uterus, rectum. And with pelvic organ prolapse, it's exactly that. One or both or all three of these organs start to descend and it feels like pressure. Sometimes it's even described as feeling like there's a tampon in your vagina or a marble in your vagina. Like it feels like something's there because it's the pressure of it. And it's either the uterus dropping down, the bladder going back into the front wall of the vaginal canal, or the rectum coming forward into the back wall of the vaginal canal. And it feels heavy, it feels like downward pressure, but then you have your pelvic floor right under it acting as a support, and you can strengthen your pelvic floor with movement and exercises and breathing.
I work with a lot of clients who have hysterectomy, and so now they're starting to experience a lot of changes in their pelvic floor.
Yeah, hysterectomy, like any sort of surgery in the pelvic region, is going to affect the way that your pelvis feels, right? One, after any surgery, there's always scar tissue that is just a result of surgery. And that scar tissue can get really stiff or tight and compress nerves or just make movement that much harder, which can lead to pain and discomfort. Then also your pelvic floor muscles, this is a really important part of any pelvic surgery. Your pelvic floor muscles, you can consciously control. You can squeeze them, you can release them, which is great. That prevents you from going to the bathroom when you don't want to go to the bathroom. But your pelvic floor muscles are also innervated by your autonomic nervous system. So there's a part of these muscles that you don't have full control over, like conscious control, thinking control. And because of that, after any surgery, sometimes you'll get a muscle guarding response of like a contracting in these muscles. You're not consciously contracting them, but it's happening.
Yeah.
And it's almost like a protective mechanism because surgery is a trauma to your body and it's just your body trying to protect you. So those muscles can get really stiff and tight after a hysterectomy or after any sort of pelvic surgery, which can sometimes lead to pain or dysfunction, and that could show up as incontinence or other issues.
And I think that's a great segue into why tightening or just going straight to strengthening, holding, gripping, clenching, things that people maybe instinctually do to stop unwanted release of fluids or otherwise, why that can be counterproductive.
Right. I see this online all the time of strengthen your pelvic floor, strengthen your pelvic floor. If you're in menopause, strengthen. You need to strengthen so that you're not leaking. Oftentimes, though, the root cause is actually more of a tightness, a gripping in your pelvic floor. And you have to address that before you get into the power of the muscle, the actual strength component of the muscle. It doesn't mean if you have tight muscles, then you shouldn't contract the muscle. I always compare your pelvic floor to your arm, right? If your pelvic floor was your bicep, you came in and you're like, it's stuck, right? I can't move my arm. It's tight. We'd want to stretch it and relax it, but also we want to just move it. We want to contract and release, contract and release. It's the same thing in your pelvic floor. If it's stiff and tight and in a holding position, you do want to lengthen it, but then you also want to bring some movement, the contract and release component.
And this is where it's so interesting for clients is that when a muscle that's being held closed and short and tight and locked short for so long, it doesn't do well at holding in.
Exactly.
So it just gets fatigued or exhausted, just like I used to waitress and I used to be a server. And so I would hold that tray of like 5 plates of ribs.
Right.
And it's just at a certain point, it's like the arm just wants to give. So it's contracting, it's working, it's holding, it's trying to hold this up, but only for so long. And just like any other muscle, it will give out.
Right. Yeah. And another analogy to think about it, I really like that one. I'm definitely going to take that.
Sure, yes.
To explain to people. That's a nice one. I like that. Another one is the same thing. If your arm is stuck like this and you go to reach for your water bottle, it's really hard to, like, you have to move your whole body to go reach for that water bottle. You have to lengthen to then pick up your water bottle and contract it again.
Yeah.
The lengthening has to come first in order to do the functional.
Yeah. It's just like any other muscle in the body. I think just sort of normalizing like it's just muscle. This is just, it's an area that has a lot of energy, history, and it can hold trauma, but it's just like any other part of the body. We need it to be responsive, dynamic. It can shift, it can shape, and it change. And that's entirely normal. And I think that that's where the link to the breath becomes so vital, is that these structures move with the breath unconsciously and consciously, which is such a beautiful thing that we need our pelvic floor to do its job without us thinking about it.
Right.
But when we need to think about it, we can. Mm-hmm. And then that just helps the whole system do what it should anyway. Can you link this to breathing for us?
Yeah. So when you're breathing, like you had mentioned before, it works with your respiratory diaphragm. And I'm doing this because that's how they mirror
She's
each
holding
other.
she's got her palms facing each other as though she's like holding a cake. One hand on top of the cake, one hand on the bottom of the cake.
Exactly.
And that's your entire core.
That's your entire core. The top of your core is your respiratory diaphragm. It's like a dome. It's shaped like a dome. The bottom of your core is your pelvic floor, the pelvic floor muscles, and that's more of a smiley face. And when you're breathing, this whole structure, the two move down together to create more space for your lungs to fill up and expand. And then when you exhale, the entire structure moves up to, I think of it as like pushing the air out of your body, out of your lungs. And it's happening like this all day long. If you look on an ultrasound and you see the pelvic floor, let's say right now you're sitting or lying down, just breathing at a kind of a low level breathing, there is this constant rise and fall of the pelvic floor. It's small. It's a little bit smaller than the respiratory diaphragm because the muscles themselves are smaller, but it's constantly moving up and down, up and down.
Yeah. It's very subtle. And I think that the first time I had to tune into this, as a practitioner, I was like, I don't feel anything.
Right.
And this is part of the work that we do with clients. And I'm a yoga therapist. I don't specialize in the pelvic floor, but everybody's got something going on with the pelvic floor. And everyone's got something going on with their breathing, and everyone's got some dysfunction in the core, and this is an essential part of the core. And to me, it's like the prodigal son. It's like welcoming the pelvic floor back into an understanding of your breath cycle and how your core functions. Everybody wants a strong core. Everyone wants to feel strong. And this is an essential part of just understanding how this system works.
Right. And I think that's where yoga is this missing link in pelvic health therapy. And it was interesting because when I first went into this field as a student, you really you go the path of your mentor because you're a student and this is what you know.
Sure.
And a lot in physical therapy, and it's so helpful and vital, and I still do this with my clients, is a lot of manual therapy where you actually will work on the muscles directly through sometimes an internal exam, if that's okay, or externally to help release the muscles if tension, let's say, is the issue. But what I love about yoga therapy is you can access that without always needing to touch. Touch is sometimes needed, but it's also sometimes not. And it can be a lot more accessible to learn how to release these muscles through your breath without always needing to directly touch them.
Yeah, it's a big thing for someone to go into pelvic floor therapy. I had one client who had been referred to go see a pelvic floor therapist and didn't realize the work would be internal. And it was such a shock and so upsetting for her.
Yeah.
And then she never went back. But yeah, that's so interesting that this release of tension and this ability to feel the movement. Do you feel like once the tension starts to dissipate, you'll sense the movement, or you can feel the movement even when it's still holding a lot of tension?
First, you need to release the tension, and then it's easier to feel the movement.
Okay.
Typically, that's how it will work. A lot of it is also working on the nervous system, your just general proprioception of your pelvic floor. And your proprioception is just your brain's knowledge of where your body is in space and how it's moving in space and kind of mapping it out. So that's a huge aspect of pelvic health therapies. You can't see your pelvic floor muscles. If you could see them, like your hand, you'd know, okay, it's moving up, it's moving down, and you'd have a point of reference. This is very internal. It's very introspective, right? It's that like being able to sense it from the inside, which is hard. That's a hard thing to master. That's difficult.
Yeah, and I love it. And I love that we've got these boundaries of the sit bones and even the tailbone and pubic bone may be less cued in a yoga class, but certainly the sit bones are referenced hopefully fairly frequently throughout your yoga practice. You're going to be hearing about the sit bones. Is that where you would start, or you start sort of tailbone, sacrum to sort of feel this movement with the breath? Or
I think the sitting bones are really accessible, and it's a great place to start since that is definitely a term that's used in a lot of yoga classes. Even just a huge part of yoga is sitting cross-legged, sitting upright on your sitting bones. That's step one. You're actually sitting on your pelvic floor. That's what you're really sitting on. So yeah, that's a great place to start. And then to feel the movement, it could be a lateral side-to-side shift on the sitting bones to feel the bony landmarks, a forward back, pubic bone, tailbone. I'll often do that in prenatal yoga classes. I'll teach how to really map your pelvic floor out and feel it and to imagine this diamond. Sometimes we'll do some self-touch to feel the sitting bones, to feel the pubic bone, the tailbone, and then we'll do this pelvic rocking to find the boundaries and to create that diamond shape.
are you doing that on a chair or on a bolster? Block?
Sitting on the floor or sitting on a bolster.
Okay, like cross-legged?
Cross-legged.
Yeah.
I think sitting on a chair would be even more accessible.
Yeah, just kind of getting the legs to drop down. And it's so interesting just trying to find the right position to help someone start to feel these landmarks. And you usually start that seated versus
I'll start it seated. The thing is, it depends on where you're at in your pregnancy and what else is going on. But in a prenatal yoga class, a lot of times sacroiliac joint pain is pretty common, and that's pain in the back of your pelvis. I'll show it on the model. That's your, let's see, this is your sacroiliac joint. It's not usually this flexible.
So she's pulling the sacrum away from the ilium, that big hip bone on the sides. You have those two SI joints, one on each side. And most women will know where those joints are.
Yes.
Especially if you practice yoga, and especially if you've ever been pregnant and had a baby.
Right.
You become very familiar with this area. I had a lot of sacroiliac joint dysfunction postpartum.
Yeah.
And I remember, luckily I'd had prenatal yoga, and my teacher was like, just don't assume that your pelvis will just automatically return to some sort of organized state after birth. And it was the best advice that I had been given was to then go get help
Right.
reorganizing this so that it could function as it should.
Right. Yeah. So that area can often get really painful and tight or stiff. And so sitting on the floor cross-legged when you're pregnant and having sacroiliac joint pain can be difficult sometimes. So sitting in a chair is actually a really nice alternative.
Yeah. I've had people sit on a rolled up mat or a partially rolled up mat or a towel or the way I originally had learned it was like a folded up yoga strap, which is sort of very, very intense if someone has a very tight pelvic floor to sit on a folded up yoga strap. But something there, a ball is wonderful.
Right.
A squishy ball or an exercise ball, but some sort of surface. I take a standard bolster and turn it on its long edge and then straddle it. I say like you're getting on a horse, but you're sort of straddling it. And so you have that soft, very soft, flexible, domed, but narrow structure that you sit across. You kind of pull the gluteals out from the side, just like you would in a yoga class, like reach underneath and pull that flesh back. And you can kind of see if you can be symmetrical on top of this bolster. And when you inhale, the surface of the bolster yields downwards. And then as you exhale, the bolster feels like it rises up into that space, which is kind of a nice way to start to feel the natural movement of the breath with the pelvic floor.
Yeah. There are a lot of options, and using some sort of support to feel that area is huge because you can't see it. You need something to act as your second eyes.
I remember I was like in my third trimester and we would straddle this yoga ball, this exercise ball. And it was so amazing to have the pressure off the pelvic floor and to feel that area rise up. And I was like, this is the best thing I've ever felt in the world.
Yes. Yeah, the exercise balls are great. Also the peanut ball. Do you know that one?
Yeah, I've seen them.
Yeah, they'll have those in labor and delivery.
How do you position that?
You can sit on it like a bolster in Virasana.
So it goes like front to back,
pose.
the peanut?
Yeah, you can sit in that divot.
I see.
And straddle it. It's also used for birth positions where you're lying on your side and you would put your thigh into the divot of the peanut ball to get that top leg into some internal rotation to help open the bottom of the pelvis.
Yeah, is that adduction or internal rotation or both?
Rotation.
It's more just the rotation that you're looking for, but the knee doesn't have to necessarily be narrower than the hip.
No, it's more the internal rotation. The idea is that when you internally rotate your hips, you're actually widening the sitting bones and you're opening the pelvic outlet. So that's the bottom of your pelvis where you would birth a baby.
Yeah, that's so interesting. I use that so much, I think, with abduction that I try to get those knees wide, and then we can work that upper inner thighs back. And these are these common cues that you've heard through episodes, certainly in Downward Facing Dog. Jane and I had a big debate about internal rotation or not, and just starting to distinguish the difference between the knees widening, which is hip abduction, and the knees narrowing, hip adduction, adding towards the midline, and then the bones can spin. So if I really am very interested in this.
Yeah.
So when the femur internally rotates and that greater trochanter is just spinning out and wide, that has an effect necessarily on the sit bones, or incidentally, it's like a coupled action?
It's a coupled action, and it's a more of an effect on the pelvic floor. A good example.
I'm going to try this as you're talking.
Yes, you have two muscles in your pelvic floor that rotate your hips, that externally rotate your hips. So when you internally rotate, you're stretching those muscles, your piriformis and your obturator internus muscles. You're starting to get that action of widening. And when you go into that internal rotation, you can start to then feel this opening in your sitting bones. There's also a bit of like taking your abductors to the side of your pelvis. I'm holding up the pelvis
so
right
the
now.
Muscles on the side of the pelvis.
The muscles on the side of the pelvis, engaging those to actually abduct your pelvis Not just your legs, your
Yes.
thighs, but your pelvic bones and separating those. So it's hip internal rotation and some pelvic abduction, like the sitting bones of your pelvis separating apart.
This is so fascinating.
Yeah.
I have worked a very long time with a teacher who worked a lot of hip abduction, and I was abducting so much that I started to feel my pelvis like coming apart. And then for me, it was really kind of driving the femur heads in, more of a corn cobbing action as the knees apart. And that, to me, that helps that compactness in the pelvis that feels very stable. But just like anything can be overdone, right? So as the knees widen and those femur heads drive in, you can still, I can feel it now. I can abduct the halves of my pelvis.
The halves of your pelvis. That's a good way to explain it. It's also doable in a...
I feel my whole sacrum like wants to come apart.
It can spread apart, and it's easier to feel in what's called a closed chain movement, where your feet or your knees are planted on the floor. So you have like something to move against.
Yes.
Right?
Yes. And maybe that would help it not go too far.
I think it's also just, it gives you some sensory feedback of like, okay, I can feel that movement.
This is so interesting because the open chain nature of so much of yoga, so many things can be moving instead of what you're trying to target, especially if you're targeting something that's guarding and it through a protective mechanism doesn't want to release. You're going to get hip hiking and you're going to get rotation. You're going to get all sorts of things in the lumbopelvic region instead of actually getting this movement in the pelvic floor muscles.
Yes. And I'm kind of going off of what I see online and a little bit of myth busting, because that's always fun to do. I see a lot online of do this to stretch your pelvic floor. The bulk of your pelvic floor muscles are sort of this hammock shape. They're very small and they don't stretch a lot. They don't lengthen a lot. We're talking centimeters. Like it's tiny. It's not a lot of movement and stretching. You can have a feeling of lengthening, but it's nowhere near as much movement as extending and straightening your elbow or stretching your hip. These are small movements. Even that abduction, the separating your pelvis, it's a very minute, tiny little movement.
Yeah. And so the stretch sensation, I mean, to me, it feels like an expansion.
Mm-hmm.
So it doesn't feel like a stretch.
Right.
Like in my hamstring, stretching my hamstring is like so enormously different. Or stretching my quad, there's so much sensation. But when I do that work in the pelvic floor, it just feels expansive. And I guess I've learned to call it a stretch. It's interesting. Yes, to stretch the pelvic floor could be a tricky word. So I've learned that tiny muscles are stabilizers, but then they have to yield so much to pass a baby. But that's when you have those hormones informing it. So I guess my question is, what is this muscle really supposed to be doing? Mostly stabilizing or mostly yielding? In our next episode, Dana and I move from understanding the pelvic floor to understanding how it functions in real life. We dive into pressure, intra-abdominal pressure, posture, scoliosis, asymmetry, pregnancy, and what a pelvic floor contraction is actually supposed to feel like. If today's conversation helped you see the pelvic floor in a new way, I think you'll love where we go next.